Hello everyone. Welcome to the Pain and Addiction Challenges and Controversies webinar. We're glad to have you here with us today. My name is Tanya Hyde and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Gaming Grant through the BC government, as well as donations and memberships to CIRPD. As I mentioned, my name is Tanya, and I'll be moderating the webinar and the Q&A session. And our presenter today is Dr. Mel Pohl. Dr. Pohl is a board-certified in family practice and addiction medicine. He's the Chief Medical Officer of Las Vegas Recovery Center's Pain Recovery Program. He's the author of A Day Without Pain, and his newest book with Kathy Ketchum is The Pain Antidote: Stop Suffering from Chronic Pain, Avoid Addiction to Painkillers, and Reclaim Your Life. We're very glad to have you here today, Mel. I will hand it over to you.
Great. Thank you. Hello, everyone. Doing a webinar is the hardest thing for me because I don't know if anybody's there. So I just trust that you're there, and hopefully you'll get something out of the time together and ask questions if you have them. So I want to start out by differentiating acute pain and chronic pain. Acute pain is functional, purposeful pain. It's a warning that something's wrong in the tissue. It's like an alarm clock going off. When the pain is not needed any longer, in other words, when the tissue heals, the pain goes away. Turn the alarm clock off, we wake up. Chronic pain, on the other hand, is long-lasting, lifelong, perhaps intermittent, but really never goes away. And the function of pain has been lost along the way. It's maladaptive pain. And what I'm going to speak about today is really chronic pain and how it interacts with people's behaviors and with their use of substances, and for some, the development of addictive disease. I'd like to start with some fallacies about chronic pain, and really the misunderstandings I think have resulted from lack of differentiation. If we take our presumptions about acute pain and translate them to chronic pain, we develop some real misconceptions. The only similarity between acute and chronic pain is really the word pain. So the first fallacy is that pain is a symptom of disease or tissue damage, and that if you correct that damage, the pain goes away. So if you do the proper procedure, if you cut out the disc, if you decompress the nerve, the pain that was there will diminish and go away. The second fallacy is that the pain is proportional to the amount of tissue damage. A bigger disc causes more pain, more swelling, more experience of pain. But the third fallacy is that if we do enough tests, do lots of tests, do sophisticated scans and injections with diagnostic tools, if we do enough of those, we'll find the peripheral driver of the pain. And if the fourth fallacy is that if we fix these peripheral abnormalities, the pain will go away. Again, not true. And then the last and one of the most important fallacies is that the lack of physical findings should lead us to question the validity of the pain. And that really is probably the most damning misconception about pain and causes the most problems for my patients. So the truths, the five key facts that drive my understanding of chronic pain are first and foremost that the pain is real. All pain is real. Now, not necessarily real in the context of tissue-related changes, but real in the experience of pain. One of the real problems that I see with patients that they express to me all the time is that people don't believe that their pain is real. People doubt it. And when I ask an audience about why that is, they impose their scale of the subjective experience pain on the patients. I wouldn't feel that way if my pain was an 8. So therefore, they're not being accurate. The second is that often when people report their pain score, what's your pain out of 10, they're associating the high pain score with acquisition of medications. And we'll talk quite a bit about that phenomenon. The third is that there's no real objective way to measure pain. I can't hook them up to a painometer or a dolorimeter. So I rely on people's subjective report of their pain score. Now, if they say 20 out of 10, it can't be 20 out of 10 because 10 is the worst pain possible and usually associated with an emergency room visit and imminent loss of consciousness. The result of being disbelieved in a doctor's office or in a therapist's office or in a family setting is devastating. The patient's veracity is questioned. And that there's actually a report in the Journal of the American Medical Association, the cost of disbelief, of being really told that you're lying, is very high. Now, the second question that comes to me all the time, and I run a treatment center. We have an addiction base in the 12 steps. We find people coming to us on very high doses of medication, specifically opioids. We detoxify them from the opioids, medically manage their withdrawal, and then we holistically manage their chronic pain. And so the people that refer patients to me are often very sophisticated, and the question that they ask is this real pain or emotional pain? And I always answer the same way. Yes, the pain is real, and yes, the pain is emotional, because emotions drive the experience of chronic pain. And here's, I think, where we miss the boat. For some reason, we disconnect the mind from the body, and we say if it's related to anxiety and fear and anger and stress and a depressed mood, that in some way that makes it less real. And I challenge each of you to understand and explain that to yourself and know that, of course, there's a physiological basis to emotions. There are neurotransmitters. They work within the neurons to cause different changes. We know for sure that chronic pain looks very different than acute pain from an MRI standpoint and from a cellular level. And that's been proven, and we had some MRI studies to show that. My experience is that fear of the pain is more disabling than the pain itself. People really struggle with anticipation and cognitive distortions around what's going to happen to them. They resist the pain, and that makes it worse. There are two kinds of suffering. One leads to more suffering because of wanting it to be different, and the other leads to the end of suffering in the way of allowing and accepting the pain. So the third issue is, what do we do about chronic pain? And the standard, certainly from a medical model, is if you have this pain situation, I want to take it away. And opioids are the solution often, and there's very good data that says that opioids often make this pain worse. People have sort of this futile search for becoming pain-free, and the benefit versus harm of opioids are really well established. We know that opioids are actually pro-inflammatory in many patients who take them. They cause more pain with the opioids than without the opioids, and that's due to cellular changes in the glial cells that support the neurons, and also in neurotransmitter changes, specifically an increase in glutamate and NMDA, which activate the nervous system and cause more pain. And the proof of this thesis is that we take people off their opioids. They come in on high doses of opioids, well more than 100 milligram equivalents of morphine per day, and without the opioids, their pain scores are reduced by 20 to 40%. So something to really think about in our management of chronic pain. The fourth issue is, if we're going to treat chronic pain, we ought to make people better. I mean, this seems pretty apparent, but it is not the model of treatment, at least in the medical system. The question that gets asked of patients when they come to a physician's office is, what's your pain score? It's one of the first things people are asked to report. And if the pain is high, the opioid is prescribed and the dose is increased. We know from significant number of studies that on opioids, quality of life tends to diminish, and the functional benefit is not outweighed by the temporary pain relieving benefit. And yet we continue to prescribe and push the dose. We're missing the functional goal. So really it's about helping people get better, have a better life. The question ought to be, how's your life, not how's your pain? And what are you doing? And how far are you walking? And are you interacting with your family? And are you going to work? If the answer to those questions is yes, I walk further, I sleep better, I'm able to go to work, and I take some opioids, that's successful treatment. But that is not the case with the majority of patients that are referred to me, of course, but also in some clinical studies, very limited studies, but clinical studies suggest that function diminishes over long term on chronic opioids. And the last point is that expectations influence outcome. This really speaks to the power of the mind and the intention. People with optimistic attitudes do better than people who are pessimistic. People who believe that a treatment's going to work do better. Placebos really are the best example of that. I mean, a placebo works because the patient believes a placebo works. And there was actually a study recently that said that even when patients are told that they're being given a placebo, their symptoms diminish. So it's pretty impressive. What we're really looking for with people with chronic pain is some amount of an existential transformation. And I'll talk a little bit more later about what kinds of components go into that. So those are the facts as opposed to the fallacies, and that sets the stage to talk about pain. The definition of pain, both acute and chronic, is an unpleasant sensory and emotional experience associated with actual potential tissue damage. It's an old definition. Again, with chronic pain, we really need to differentiate what's going on. Now, acute pain occurs, it starts in the place where the tissue is damaged. So in this diagram, you can see that there's a nail penetrating the skin. The nail penetration causes damage to the peripheral tissue, and that tissue causes chemicals to be secreted like prostaglandin and substance P, and they cause the nerve to fire and travel up the arm into the spinal column and eventually ascend to the brain. So if you look at number 4, you can see that the signal from a damaged finger related to a puncture is going to affect both the frontal cortex, which is the thinking part of the brain, the somatosensory cortex, which is the defined localizing part of the brain, and the limbic system. And the limbic system, of course, is where the emotions happen. So there's an immediate emotional response to acute pain. With chronic pain, of course, it gets much worse. We also have pain inhibiting descending tracts in the spinal column that actually can lower pain levels or take them away temporarily. That results from the need to function in an emergency. So if you have a nail in your finger and your house is on fire, the priority goes to getting out of the burning house. You don't even feel the pain in your finger, and that's related to a tract that involves serotonin and norepinephrine, which can be utilized for various treatments for these conditions. So acute pain is transient activation of those peripheral nociceptive fibers. It's related to injury, tissue damage, surgery, nail in the finger, and when the nail is removed, the finger is cleaned and the pain goes away. With chronic pain, there are sustained currents. So as an example, I have a bulging disc at my L4-5. It presses on my spinal nerves. They travel up to my brain on a regular basis, and because of the regularity of the signal, I sort of get better at perceiving that pain. So there's a phenomenon in the spinal column called wind-up. So a single-lane highway becomes a 4-lane highway, and it's all the result of plasticity of the nervous system, changing of the central nervous system in exposure to chronic painful stimuli. The brain actually ends up misinterpreting the significance of the pain because there is an upregulation of the signal. There's also a decreased ability to downregulate the signal. So those serotonin and norepinephrine tracts are actually inhibited. And the net effect is that the pain is aggravating and irritating and frustrating, but not terribly functional. My pain in my back is pretty much insignificant in that I can walk and hike and lift weights and climb mountains and ride bicycles. It aggravates the feeling I have in my back, but structurally it's of no significance because I can do it all and I don't injure myself further. So I hope that makes sense to folks. There's a lot of things that influence the experience of pain. So, we have the sensory experience, and then we have the overall experience. So how we are raised influences our interpretation of a pain signal. There are certain cultures where people don't feel pain in the way that people in other cultures. In fact, in certain African tribes, there are women who deliver babies and they feel no pain. They express no feeling of pain. In that same culture, the men go to bed for 3 days wailing and howling with excruciating pain. So how can we explain that other than the way people are trained? The context of one's experience is going to influence how they feel pain as well. So, for example, my back is bothering me, but I'm working. I'm going to finish this webinar, and after that, I might get an ice pack and whine a little bit. But for now, in the context of doing my job, and actually, when my focus sharpens, it really diminishes the pain signal. And there's a neurophysiologic way that the brain does that. The periaqueductal gray area of the brain lights up when people are doing tasks, focused tasks. And my personal experience is that I don't feel my back when I'm working hard and really engaged in the process. Anticipation and previous experience are key factors in people's pain tolerance and threshold. We have a lot of patients who come with a set of expectations. It's happened before. I know it's going to happen again. My favorite misconception is someone who comes in and says, my pain is a 4, but it's rising. And I really challenge patients with those cognitive distortions and ask for an explanation of what does it mean that your pain is rising. Right now, this minute, your experience of pain is what it is. It typically is, it changes over time because when it goes from a 4 to a 6 and a 7 and an 8, that's the pattern. And we try and tease out the fact that that anticipation results in an increased pain level because of tightened muscles and decreased respirations and emotional distress that raises sympathetic nervous tone, which increases pain. So that's one really clinically that we can impact with proper instruction and practice. So it's clear that emotional and cognitive factors influence pain. What we think about the pain and how we feel about it makes the pain worse. The 3 key emotions are anxiety, anger, and fear. But depression and guilt and shame are right in there as well. It probably wouldn't surprise you to know that some people feel more pain than others. They're more sensitive to pain. I have a sensitivity to pain so that the same stimulus in one person causes more pain in some than others. And the explanation of nociception becoming high pain or low pain is explained in part by the pain switchboard. And that switchboard is mediated by an enzyme called COMT, catechol-O-methyltransferase. COMT metabolizes a number of catecholamines, one of which is dopamine. You're familiar, I'm sure, with the fact that dopamine is a neurotransmitter of well-being. Certain people metabolize it differently so that nociception, or a poke in the chest, becomes excruciatingly painful with one variant of COMT and quite insignificant in another variant of COMT. And what that really means is that there is a heightened sensitivity to the pain or a lower threshold to feeling the pain. And there are 2 factors that influence COMT levels. One is genetics. We know that people inherit a tendency to be more sensitive to pain than others. We see that with family histories, and particularly cogent with children of people with high pain levels end up being very sensitive to pain. The second key factor in changing COMT and resulting in a lower pain threshold is the experience of trauma. 80% of the patients that we see here at Las Vegas Recovery Center have significant life trauma, and it can be a particular insult like sexual trauma, being raped, or physical trauma, an injury or accident, witnessed the trauma, the people who are first responders who witness atrocious things, or veterans who come back from a war zone. And then we see people who've been medically traumatized. I had a conversation with a young woman who has a chronic medical condition that was misdiagnosed. They basically sent her to psychiatrists without any real insight to the fact that she had a medical condition. She'd had a bunch of surgeries and tests, and it's like the train of diagnosis got derailed by the assumptions around, the misconceptions around chronic pain. So, and that in and of itself is a trauma from the medical system. So I think we as clinicians can impact all of those forms of trauma, and they need to be paid attention to. We have significant trauma specialists. We have an EMDR specialist here. We deal with trauma on the level that it can be dealt with. So some people are ill-equipped to do anything but learn distress reduction. Others need to deal with the issue more in depth. But anybody who's had trauma is going to be subject to higher pain levels, and they're going to need some treatment for that. What we find is that the conditions with a higher sensitivity to pain or a lower threshold, like fibromyalgia or chronic headaches or irritable bowel syndrome or interstitial cystitis or complex regional pain syndrome, these are all conditions where people feel more pain, and I'm putting the quotes around this, more pain than they should. And what we know about these people now is they have a thing called central sensitization syndrome. So the normal pain response that you're looking at becomes this. So the firing of the various areas in the brain that perceive pain is higher because of a variety of factors, some of which are genetic and trauma. So once again, normal pain response and the heightened pain response of central sensitization. These folks are misunderstood because we don't really have active measurements of these experiences. So people get, really, I gave a talk to a bunch of pain physicians. There's a conference in Las Vegas once a year called Pain Week, and I asked how many of the pain physicians believed that the chronic pain of fibromyalgia was a real illness, and only half the room raised their hands. Well, this is fibromyalgia we're looking at. It's a patient with a hypersensitive reaction in their brain. People have pain and people suffer. So when touched with a feeling of pain, the ordinary uninstructed person sorrows, grieves, laments, beats his breast, becomes distraught. So it feels two pains, physical and mental, just as if they were to shoot a man with an arrow and right after were to shoot him with another one. So he would feel the pain of two arrows. So we're really talking about the painful stimulus, the nociception, and the overall experience of pain, which is the human response that results in suffering. And that was said, of course, hundreds and thousands of years ago by the Buddha. What we really are concerned about here at Las Vegas Recovery, the people that we see referred to us have chronic pain syndrome. So it's not just pain more than 6 months, it's emotional responses that are dysfunctional and limiting: depression, anxiety, anger, and fear. People have restriction of their activities. They're using medications excessively and the medical services. They may have addiction or simply physical dependence. We have done, the system has done non-productive test treatment surgeries to get to the answer that is unanswerable with those tests. And there's no clear relationship to the GAG disorder. So these are people who really suffer from the system's misinterpretation of the fallacies that I started with. Pain score 1 out of 10, or identify the face that describes your pain. It's whatever the patient says it is. That's the definition, unless we can prove otherwise. Well, there is no way to prove that somebody has a level of pain that they say. There's no dolorimeter or painometer, and there are some lab, Stanford has a functional MRI machine that actually can measure and quantitate a pain experience, but it's still very subjective because my 8 is different than your 8 is different than his 8. Pain management goals really must be to improve life. And I think we've missed the boat in our attempts to decrease pain. So it's really maintain and hopefully improve function. And our pain goal is to reduce discomfort by 50%. And part of that is the perception of pain and the suffering related to it. And those are achievable goals, by the way. There are a number of non-opioid medications that can be used, anti-inflammatory medications like ibuprofen or COX-2s like in the States it's Celebrex, and other anti-inflammatory medications. They're going to work in the periphery. They really don't have a central effect, but they're very effective. There's one head-to-head study of hydrocodone and acetaminophen combination versus ibuprofen, and the ibuprofen and hydrocodone had equal effects of analgesia, same analgesic effects, but the opioids, of course, affected anxiety, anger, and fear. The ibuprofen did not. And often patients will say that anti-inflammatories aren't effective because they're expecting and wanting a cerebral effect, and that may be associated with addictive disease. Antidepressants work on serotonin or norepinephrine, so the sedating antidepressants like amitriptyline or nortriptyline, and then the SNRI, serotonin norepinephrine reuptake inhibitors like duloxetine and venlafaxine, as well as others, work to enhance our naturally occurring pain-relieving tracks. Anti-seizure medicines, gabapentin, pregabalin, for headaches, topiramate, and sometimes Lamictal or lamotrigine can have an effect on central pain and also on neuropathic pain. Muscle relaxants, any one but carazoprodol. I don't even know if that's on the market in Canada. It is in the States as Soma. Turns into an old-fashioned anxiolytic called meprobamate, which is as bad for somebody with chronic pain as a benzodiazepine. So muscle relaxants, other than carazoprodol, may be effective. It's not clear that they really are, but we'll use them on occasion. And then the last is topical preparations. It could be topical lidocaine or anti-inflammatories or even anti-seizure medicines are available. Capsaicin is an inflammatory chili extract that causes a burning sensation that can wipe out the actual pain experience. So opioids are not the devil. I'm not opiophobia or anti-opioid, but they are not appropriate for all people with chronic pain. If we're going to try an opioid, we should do it as a clinical trial. And what a clinical trial means is that we prescribe it and then we check back with the patient on their function. If during the assessment their function is better, their pain is improved, and the side effects are tolerable, then we continue. If, on the other hand, function is diminishing even though the pain is somewhat better, that's not a good clinical trial, and we ought to have an exit strategy to discontinue the opioid shortly after we started if it is not clinically successful. And I think that's where we really miss the boat. There's been a lot of literature coming out of the American Academy of Neurology here. As you can see, the benefits versus the harms. The CDC has just published their guidelines for practitioners, and they pretty much say it's very unlikely that opioids are going to be helpful in the long run for people with chronic pain, partly because of tolerance and partly because of all these negative side effects. Other problems related to side effects include, of course, the worst problem is constipation. And everybody rejoiced when they invented 2 new drugs for opiate-induced constipation. I'm saying that tongue-in-cheek because there's something wrong with a system where we have to develop an expensive drug to counteract the drug that we're prescribing, especially if that drug isn't working very well. Other side effects of opioids are cognitive slowing, sleep disturbance with apnea episodes, immune system function, T4 cell changes, and CD8 changes, and lastly, endocrine changes, so lowered testosterone and estrogen, which can actually result in bone density problems, both for men and for women. So if somebody's on chronic opioids, it's now recommended that they get bone density studies periodically. Everybody gets tolerant and physically dependent to some extent or other, and different related to probably genetic background and other factors. But tolerance means you need more over time. Physical dependence means you can't stop without medical assistance. And that's one of the main reasons people continue these drugs, is that they are in withdrawal a good part of the time. People lose their function because of the opioids. There are patients who are treating their emotional pain with medications. And they've been called in the past chemical copers, people who perceive their emotional pain as physical pain. There are some, I think, pejorative terms like somatization. These are the people that have central pain and are taking the drugs for anxiety, anger, and fear, and getting into trouble because of that. And lastly, I mentioned opioid-induced hyperalgesia. Here's what it looks like. It's a 2003 study in the New England Journal. You can see in the middle of the graph, that's as good a pain relief as we're going to get. If we continue to push the dose of opioid, the pain level goes up. We're in the States in this pendulum swinging phenomenon where opioids are terrible, the devil, they should be illegal and outlawed, to the beginning of hospice where opioids were valued for people who were at the end of their life because we don't have to really worry about what the consequences and side effects long-term are going to be, and certainly not worry about dependence and addiction. And now we're in a stage where the pendulum swung so far back that it's opioids for everybody with chronic pain. That is the wrong tack to have taken, and we have a lot of complications as a result of that. OxyContin was one of the best examples of our DEA allowing a drug, oxycodone long-acting, to be released. You take that tablet, crush it up, and snort it, and you've now got a highly intoxicating, highly addicting version of oxycodone. One of the solutions that the DEA and the FDA and the manufacturers come up with is that we make a crush-proof version of OxyContin. And as you can see, we can freeze it and crush it, according to some of my patients, put it in the microwave, or simply buy a drug like Opana, which is oxymorphone, and other non-deterred forms of potent opioids. People are taking their fentanyl patches and cutting them open and sucking out the active liquid. So it's hard to litigate and chemically remove the risks of these drugs, and yet our FDA just approved a long-acting morphine version because we don't have enough opioids on the market. We're in an opioid epidemic. These are a representation of admissions for treatment for these prescription opioids in the states, and you just look at the red states from '99 through 2007 and 2009, and you can see that the incidence has increased dramatically of the need for treatment for these opioid medication overdoses. I'm sorry, that's not overdose, that was treatment for dependence. The overdose rates have risen, 19,000 last year from prescription opioids, over 30,000 opioids in general, and that of course includes heroin. This is in the States significant, more than cocaine and heroin combined, though between 2007 and 2015 the heroin curve unfortunately has gone up substantially, and I'll show you that in a moment. In the States, more overdose deaths than motor vehicle accidents deaths. That cross came around 2009. And I have one piece of data from Canada and BC. This is the death rate from opioids and related narcotics, and as you can see, it includes accidental and suicide overdose, but the pointing of the curve is really the most important thing to notice. We know that the higher the morphine equivalent dose, the more the risk, and as you can see, if we get beyond 50 milligram equivalents of morphine a day, we go from a risk of 3 to a risk of 11, and that middle range is where the CDC has told us we should stay below 100 milligrams of equivalents, and really in the 50 milligram range if somebody's going to be on chronic opioids. Opioid sales are up in the United States. It's a very profitable way of doing business. They do it by misinforming physicians. So I'm going to rant a little about the pharmaceutical approach. They told physicians that we're opiophobic. They told us that opioids are safe and effective for chronic pain with no studies to prove it. They said that opioid therapy can be easily discontinued if you're taking them for pain, which is erroneous and ridiculous. And they told us that opioid addiction is rare in pain patients based on a study by Porter and Jick in the New England Journal in 1980. Now, it's an old study, but people are looking at it still, and it says only 4 cases of addiction among almost 12,000 patients treated with opioids. If that were true, you can't get addicted if you have pain. Well, ridiculous. The study, it was a retrospective study. As you can see, 12,000 patients relieved at least one narcotic preparation, only 4 cases of reasonably well-documented addiction, which was, they write it in the chart. So it's not a study, and it was quoted heavily, and it still is referred to. It's a moneymaker in the United States, $12 billion in 2013, simply on OxyContin. They do it by advertising here. The message is, my life gets better. The facts are that it doesn't. Freedom from pain allowed by the FDA, but recently that's been prevented so that long-acting opioids cannot retain the label safe and effective. Our Joint Commission has mandated checking the pain score on every patient. It's called the fifth vital sign. Big mistake, and they're trying to go back on that as well. The AMA has come out against the fifth vital sign. Methadone in clinics is, of course, in liquid form, fairly well-controlled. Methadone for pain in doctors' offices is the #1 cause of overdose death in 2010, 2011, and that has continued on through this decade. As I mentioned, heroin has made a big comeback, and this is the most disturbing part of the epidemic. Death rates are up from heroin at over 11,000 in 2015 in the United States. Medication-assisted treatment, I'll just mention, I don't have time to really talk about it, but methadone maintenance, replacing a prescription opioid or heroin with a steady dose of methadone, is one way to stabilize the opioid receptor. Buprenorphine, in the states Suboxone, Subutex, Zubsolv, stabilizes the opioid receptor as well, and is a partial agonist, so it doesn't get people quite as intoxicated as a full agonist like methadone. Naltrexone is a blocker of the opioid receptor. If people are on it, they can't get high. It comes in an oral and an injectable form. And naloxone, of course, is Narcan, reverses an opioid overdose, life-saving in the moment. There's a picture of the U.S. version of Suboxone, and this is Aviso, is one of the injectable forms of naloxone, which anybody can carry, and it's almost like an EpiPen, and it can save lives and get people breathing again. Addiction, one way to diagnose it is if people start their day with a cigarette, that is indicative of tobacco use disorder. We have much better success having our patients continue opioids than nicotine, even though there's good evidence that nicotine in smoking causes higher pain levels. I'll run through the definition. You'll get these in the slide handouts just for the purposes of time. But this chronic disease is reflected by an individual pathologically pursuing reward and or relief by substance use or behaviors. It's the pathological pursuit of relief that really defines addiction or complex dependence, as we call it, in patients who are in chronic pain. So they're not getting high, they're not having fun, they're really searching for relief. The differentiation between pain patients and drug abusers is a false one. The truth is that 63% of patients admitted to using opioids for purposes other than pain who had a prescription, 35% met the DSM-5 criteria for addiction, and 92% of opioid overdose decedents had a prescription for opioids for chronic pain. They weren't getting them on the street. So we have, if people are taking opioids for pain, we can't conclude that they don't have addiction simply because they're taking them for pain. Chronic pain results in fear, and fear results in diminished function because it hurts when I do this, so I don't do this. I have decreased mobility. my function is altered, my self-efficacy is diminished, and my social limitations are increased, and I have more pain. Ways to reduce pain intensity, certainly cognitive behavioral therapy. There's hundreds of studies proving efficacy of a variety of cognitive behavioral methods. It's really helping people change the way they think about their pain. Other emotional and cognitive interventions include dialectical behavioral therapy and acceptance commitment therapy, and there's a pretty good database for both of those therapies with chronic pain patients. Distraction works. When we have studied people's attention, if they are distracted, their pain levels go down. The problem with some of our chronic pain patients is that they can't successfully distract themselves for long enough to get relief, and we work with mindfulness practices with those patients. A sense of control and placebo, as I mentioned, whether you know it or not, is a positive way to impact somebody's chronic pain, and reducing fear reduces pain. The best way to reduce fear of pain from movement is movement. So motion is lotion. We encourage people to exercise. With exercise, mobility is increased, circulation, tissue adhesions are lessened, function improves, I feel better about myself, and I have less pain. 3 pearls about pain. One is that conditioning increases pain. There was a study of a person with back pain who got shocked in the back, and pain score was measured in the presence and the absence of a solicitous spouse. In the presence of the solicitous spouse, the pain scores were double. So it has a lot to do with our connection with somebody who has pain. We know that pain patients are in pain, and that's because of mirror neurons. Actually, we do feel pain in other people because of the way our brain is structured. And lastly, secondary gain prevents getting well. If people are benefiting from their pain, subconsciously, they will hold on to their pain. And I don't have time to get into that in detail, but it is a real phenomenon that people are paid to be in pain. They have less responsibility because they're in pain. They get attention when they're in pain, and not consciously, but subconsciously, the pain level goes up. We, rather than pain management here in Las Vegas, talk about pain recovery, and it involves developing a balance in how we think and feel around pain and other issues, physical modalities, and then a spiritual connection, which for us comes through the 12 steps and meditative practice. The result is that relationships get better and people act better, if you will. They have positive actions and behaviors. We do a lot of non-medication treatment. As I said, motion is lotion. Moving it is really the key, so people getting moving with a trainer and therapist. We have a chiropractor, a massage therapist, a Reiki master, acupuncturist, all of which have some loose data related to chronic pain, but there's certainly some subjective improvement. We pay attention to nutrition, encouraging anti-inflammatory medications and discouraging things that are inflammatory, particularly sugars. Nicotine is in that list, of course. Individual and group therapy. A lot of what happens here happens between our patients. People talk to each other, they relate to each other, they identify, and they diffuse some of that isolation. We teach people how to meditate, mindfulness-based stress reduction. There's a great literature base from John Kabat-Zinn and others who carried on his work. And we do weekly yoga and qigong. Again, just a movement activity coordinated with the breath that has some good database support to it. I think we're at the end. Just a reminder that all pain is real. Emotions drive the experience of chronic pain. Opioids often make pain worse. Treat to improve function, and expectations influence outcome. And we do have some time for questions.
Wonderful. Thank you very much, Mel. That was a great presentation. I'm sure people will look forward to having the slides, because that is also a lot of information.
I know, I rolled pretty fast. Sorry.
No, that's great. I mean, I think that's the best way to do it. The recording will be up so people can always rewatch it to refresh the information as well as the slides. So I think that'll be great. Let's see. We have a question. What role does the amygdala play in persistent pain?
It's a very astute question. Amygdala, of course, is part of the activating system in the brain. It's particularly noteworthy that amygdala hyperactivity is related to trauma, peak trauma survivors. So I guess the short answer to that is it's definitely involved. The insula is involved, and I'm not a neurophysiologist, so if I had a picture of a brain, I could show you back to that central sensitization slide. The amygdala was lit up in the pain experience and heightened in the enhanced sensitivity to pain. So it's right in there in the sense that it's an activating system and is on hyperdrive with people with chronic pain.
All right, and then someone asking about central sensitization. Since many healthcare professionals don't get it, quote unquote, or how does a patient help the professional to relate to their pain? And what do they say to help educate, in a sense, their doctor or professional?
Yeah. Well, so let's start with the clinician, because the clinician can help the patient get to their healthcare professional with some skill. Assuming that the patient is well enough educated about central sensitization, I think it's really having a conversation. You know, I often have people who say, I brought your book to the doctor's office and I showed him the pictures of central sensitization and he said, wow, I really need to do some research. So I think grounding it in reality, in clinical studies, the slide on central sensitization came from Dr. Moskowitz in 2011, and I pulled that right offline. You know, bringing those slides is really compelling, those photos of the brain. And if a clinician, a physician, isn't receptive to that message, then you got to find another doctor. It's just as simple as that. I mean, most physicians want to help and should be, I would expect, be very receptive to learning about this. And if they're not, again, you need a clinician, a physician that you can really collaborate with, especially if central sensitization is a diagnosis.
All right. Another question. The enzyme COMT, the person is saying, or whatever it was called, is this enzyme tested in patients? And are there studies which show cultures that tolerate pain well, such as when you use the example of the African female tribe members who experience no pain during childbirth? And do they have lower enzyme levels?
I don't, that's a very smart question. The COMT is not, you can't order that test in a standard lab. My hunch is, I mean, it has been measured, and there is, I think, a reference on that slide to where that data comes from. But the long and the short of it is, we can't scientifically prove in most clinical situations that somebody has elevated or COMT variant, but we can in an experimental lab. And it would be great to know if COMT variants are present in these kinds of people. I know that at Stanford, Dr. Sean Mackey's lab, they have shown differences in COMT and differences in responsivity of a variety of areas, including the amygdala, insula, thalamus, in people who have this sensitization syndrome. So there's a lot of neuroscience behind this, and there's a lot more to come.
Wonderful. Let's see. There were two questions about exercise that are kind of related. One was just asking if exercise helps reduce pain levels, which you answered a little bit towards the end with motion is lotion ideology. But the other person, I think, is asking specifically about small fiber polyneuropathy and wondering why that condition gets worse with pain with exercising, if you have any expertise in that.
There's so many positive effects of exercise, so I'll start with those. I mean, much of the experience of chronic pain is related to inflammation. So inflammation caused by inactivity of a joint or a muscle system or tendons causes constriction of the tissue with increased fibrous layering of fibrous tissue. the scarring of the area in essence. Decreased or increased exercise increases oxygenation, so there's the ability of the bloodstream to travel out toxins as they're increased with increased exercise, and other inflammatory cells. So I don't think we have data that says that small fiber neuropathy gets worse with exercise. But the real problem with exercise is it doesn't feel good when we start out. So it hurts. My patients are very interesting. We send them to physical therapy. They start out with a trainer here, and then they go to a physical therapy studio. And most people get it. They say, my belly is sore and my muscles are sore, but it's a good hurt. And they really can differentiate it from the pain that's associated with the chronicity of their pain signals. I think that graded exercise, and one of the things to be cautious about is that some of my patients want to go from 0 to 100. We had a guy who's been on a cane, and he's out power walking 9 laps on our outdoor area, and he was in bed the next day with excruciating pain. So really, it's increasing gradually over the course of time that decreases the pain, even though it hurts when we exercise. So I'm a big fan of structured oversight of an exercise program, and not to mention the dopaminergic effects and the endorphin effects on a central basis that come from increased exercise.
Wonderful. Okay, what would you recommend for social workers who are working with clients who may be addicted to opioids?
I teach a lot with non-medical clinicians, and I often get this question. I think the beginning is really to open the topic with a patient, with a client. It's really important that you stay aligned with that person and they know that they can get support from you. That said, I think so many patients come to me for assessments, and they haven't begun to get to the point where they consider coming off opioids, and I'll ask them why. The conversation is usually, how's your life? Crappy. I'm in bed all the time. I have no energy. I'm depressed. I can't lift my kid. On and on and on. And they're on high-dose opioids, and I say, why do you stay on the opioid? And they say, the typical response is, can you imagine how much worse I would be if I went off the opioid? And then they supplement that with the fact that when I go 2 hours without the opioid, I get worse. So here's where a social worker can come in, or any clinician, and say, well, here's the facts. The reason you're worse is you're physically dependent on the drug. And somehow or other, if you decide to go forward with a plan of detoxification, you're going to have to get off the opioid, and it's not going to be pleasant because your opioid system is saturated with this drug. Coming off the opioid is going to cause more pain temporarily, and then really focus on the benefits. Focus on the facts around hyperalgesia, on a functional goal system. Obviously, the social worker can't administer a detoxification plan, so they're going to have to engage somebody in the medical field to help either wean down the dose of the medication over time, which is really tough because every time the dose decreases, the pain goes up, or going in and just sort of biting the bullet and detoxifying. Bad idea to stop suddenly, but good idea to at least consider, and that may take 6 months. This is a longitudinal process, not an event. So really opening them to some ideas and helping them make a decision if they decide to do that, and then supporting them through it, in addition to teaching them skills to deal with their pain. I mean, whether they stay on opioids or not, catastrophization, I didn't mention that word, but describe the phenomena. Making things worse in our brain is characteristic, and it's actually correlated with COMT in that study. So the tendency to make the pain worse and have a larger experience of pain is modifiable with CBT and DBT and ACT, to name just a few of the kinds of therapies we can do.
Great. Do you know of any research in applying somatic practices such as CNS-focused counseling to individuals suffering from chronic pain? This is from someone who's training in somatic experiencing, like somatic treatment.
No, is the short answer. I really don't know of any of the data, but it's, we're working with the brain and the body. We're coordinating the two. How could that be bad? But I don't have a database around that.
Okay. Let's see.
Tanya, I wanted to mention one other thing in response to the social workers. In addition to advocating with the patient or with the client, going to the doc, whether it's a visit to the doctor or a letter to the doctor or a phone call to the doctor saying, hey, I'm working with your patient and she may be interested in detoxing from opioids. What do you think about that? Is that viable? Can you help him or her with that? So I think it's one other service that a non-physician can offer to their patient with chronic pain on opioids.
Very good. Someone asking if these types of pain reduction techniques that you've been discussing throughout, both medical and non-medical, work as well for Crohn's disease and irritable bowel syndrome as well?
The answer is yes. I mean, the diagnosis, in my experience, is a lot less important than the process that I described. In inflammatory bowel disease, I mean, there's clearly a basis to the inflammatory process, genetic component, a dietary component. What we can impact, whether it's Crohn's disease and certainly irritable bowel syndrome, is the effect of the nervous system, the brain functions on the bowel. That's the central sensitization part. And there is a central sensitization component, as I mentioned, with irritable bowel and probably with Crohn's. Again, please don't take that as suggesting in any way that the reality of the inflammation in the bowel is any less real, but just we can impact the second part of the mind-body continuum, that is the mind, with a whole lot of different therapies. And we've seen people with inflammatory bowel disease do incredibly well, get off their opioids, work on their diet and their thinking and their emotions, and do incredibly well.
Wonderful. Someone asking about chronic pain support groups and wondering what type of role they have in ongoing experience of pain, in your opinion.
Good question. Brilliant to access, but for some reason there's not a really substantial network of them. There is Chronic Pain Anonymous, there is Pills Anonymous that have different presence in different locales. Chronic Pain Anonymous is one to investigate and go online. They have a book and they have, I believe they have online groups as well. We started a pain and recovery support group here, which if you go to LasVegasRecovery.com, that's not up on the screen, but that's our company website, LasVegasRecovery.com. PERGS, the information for that group is there, and it's based in 12 steps. The first step in that group is I'm powerless over my pain, as opposed to I'm powerless over my alcohol or my addiction. And it parallels the 12 steps in creating a group experience. It's really beneficial for patients who have chronic pain to buddy up and to be with other people that they can identify with and connect with. And I encourage people who have a practice with a number of patients to form a group. Even if it's a support group in a doctor's office, it really can be very positively impactful.
Wonderful. Thank you very much. Well, that's about all the time we have. I really appreciate your insight and your advice and perspective on all of this, Mel. It was really great to have you online today.
Thanks. My pleasure. Thanks for asking. Take care, everybody.